Okay, I think you can get started.
Okay, perfect. So like I said, it's going to be cases presentation. I'd really like to have your input, either diagnosis or treatments. So it's really just to highlight the pertinent findings and to have some sort of approach when you get ophthalmology patients. So this is a general DDX of red eye. We're going to skip. So here it's basically the main points is that it's a young patient, recent upper respiratory tract infection. The secretions are watery. It's a lot of redness. The vision seems to be the same in both eyes, no real decrease, and people around them have it as well. What do you guys think? What would you go to?
We have viral conjunctivitis.
Yeah, I'm sorry, this one's very, very evident. So obviously viral conjunctivitis, these patients tend to have a lot of pain. So they will complain of severe symptoms, they'll have crusting. If it's in both eyes, it's kind of a reassuring sign that it's probably viral conjunctivitis and not bacterial, which tends to be just one eye. Now, say it's a young patient, it's a red eye, and there's a lot of mucus secretion every time you try to clean it up, it comes back. What is the thing you really have to fear, or what do you guys think?
Gonococcal.
No.
Yeah, so gonococcal, do you know what the treatment would be? Sorry, I don't know your names. Maybe I should, like the last person who answered, it didn't tell me. How would you treat gonococcal?
So you can use, I think they would actually need IV antibiotics as opposed to just topical, and the eye needs to be washed out regularly.
Yeah, exactly. So they do need the regular, treatment that you'd give, ceftriaxone, intramuscular, and azathiopio. It's actually a very sight-threatening infection, and it could potentially be life-threatening. So a lot of irrigation, antibiotic drops, and the antibiotics IV. So it's something to really keep in mind. It does happen a few times a year. There was one last year at the Jewish, and the ER doc was really sharp, called us at 3 a.m. Otherwise, it's usually viral conjunctivitis. So we'll go to the next slide. So here, now we're going more into pediatrics. So 8-month-old, gooey yellow discharge, eyelids are swollen, parents are really worried. If you see this, what are your DDXs?
Blepharitis.
Okay, blepharitis. Anything else?
Dactylitis.
Yeah, and say one more. So we said blepharitis, so nasolacrimal duct obstruction, so it could be dactylocystitis, and then something that we just talked about on the last slide.
Bacterial conjunctivitis.
Yeah, so bacterial conjunctivitis, exactly. So kids tend to, the highlight of this one was to say that kids tend to have bacterial conjunctivitis, adults not very likely. So this kid would be bacterial conjunctivitis. So treatments would really just be erythromycin ointment or polysporin, ciprofloxacin. Vigamox is really a big gun. You don't really need to use that, but you should refer to us. We do monitor that, and it's more likely bacterial, like I said. If it's NLDO, we also treated in those patients. Now, I put a slide in that's important to keep in mind. So say the baby's not 8 months old, but is young, less than 30 days old. It's important to keep in mind it changes to ophthalmi neonatorum. So less than 24 hours, more likely to be chemical, 3 to 5 days gonorrhea, which like in adults is an emergency, which we also treat with IV. 5 to 15 days, more like chlamydia, 7 to 14 days HSV, which we also treat PO or IV, sorry, IV in this case, with the cyclovir. I know there's a big overlap here in the 5 to 10 days. So it's really important for kids that we do culture and that we consult ID. So it's just a little reminder slide. All right, Third scenario, it's a 50-year-old, exerted himself. The vision is the same. What do you guys think?
Subconjunctival hemorrhage.
Yeah. And how would you treat that?
Nothing, just reassurance.
Yeah. Do you guys think that they have pain usually when they have subconjugate?
No.
So it's a misconception. Yes, they do. It's very irritating. They'll have burning sensation. They'll say they have pain. It's normal. It's nothing to be alarmed with. We just give artificial tears. They won't have very intense pain, but some will describe a lot of discomfort. All right, so nothing to do, and it can take up to 4 weeks to resolve. All right. It's not going too fast, I hope. They're pretty basic. There hasn't been a lot of discussion, but the more we go, the more complicated they'll get. So this one is a young patient, pimple on the eyelid, very sore, no change in vision. They might say that the vision is blurry sometimes. What do you guys think?
Chalazion.
Yeah, Chalazion. And what can we have sometimes if the whole upper eyelid is also red and hot?
Periorbital cellulitis.
Yeah, you could also have preseptal. We don't call it periorbital. We just to make a big differentiation between orbital and preseptal. So it would just be the soft tissues that are infected. It can happen with a chalazion, so it's definitely to keep in mind. And how would you treat a chalazion?
Warm compresses.
Yeah, for how long?
I'm not sure, a week.
Yeah, a week is reasonable, but it's really important to tell them that it's 10 minutes of hot compress. A lot of patients will put 2 minutes and then we'll keep coming back to the ER saying that it's not resolved. So it really needs to be hot for 10 minutes and a minimum of twice a day could be mentioned for them. And then if it does develop into a preseptal cellulitis, you should give Keflex. Usually we give 500 QID. There's a lot of differences in the literature, but our oculoplastician gives 500 QID.
Just out of curiosity, at what point, if they do keep coming back to the emergence, not resolving, they're really adamant that they're actually doing the warm compresses and stuff, when would you consider that we should refer this to you?
You could refer whenever you'd like. It's not urgent, so we usually wait 1 to 2 months to see them. But you could refer at any time if you feel like this patient's going to come back, just send us a consult. We don't tend to drain them when they're acute because there's a lot of pus and it has a high tendency of recurring. So that's why we make them wait. Just tell them, they won't get called for 1 to 2 months and that's normal. All right, here it's a 4-year-old female. It's right upper right eye swelling. It's red. The eyes closing. So what's important here is there's a lot of pain on palpation. Vision seems to be okay. Pupils are reactive. There's no RPD, and the extraocular movements are normal. The key finding here is that the eye is white. So what would be your DDX, and what would you guys do?
Preseptal cellulitis.
Yeah, preseptal cellulitis. What's the thing that you want to rule out in those cases, though?
Orbital cellulitis, so it's something I'd probably get a CT on and I'd have a consult put in as well.
Yeah, so with kids, it's a really lower threshold, and we really want to rule out orbital cellulitis. The key findings here, though, is that the eye is white. If the eye is white, the chances of orbital cellulitis are almost none, especially if the extraocular movements are also normal. You should definitely refer to ophthalmology right away. But in those cases, if we'd see it, we wouldn't scan this patient. We would treat with PO as a preseptal cellulitis versus this patient, which got a scan, which we can see clearly in orbital cellulitis. So they tend to have an RAPD. They tend to have limited extraocular movements, and that's what we call dangerous signs, fever as well. You don't see it here because the eye is closed, but the conjunctiva would be red. And this we treat with IV. We'll bring to the day clinic. All right. Okay. Okay, so this is a 50-year-old patient. Pupils are reactive. There's also pain on extraocular movements, and there's pain if you touch the eyelid or the globe. Now, here they said that she has some sort of inflammatory disease. It's a little hint. What do you guys think? What's your two DDXs?
Uveitis and scleritis, I guess.
Yeah, so these are the two things to keep in mind, definitely. You guys are really sharp. So yes, uveitis, especially if they say that there's photophobia, that the vision decreased. Here with the pain on palpation, it would more be scleritis. You should refer to us. We treated, do you guys know how we treat scleritis?
I think you put drops of corticosteroids.
So that's a common misconception. So drops of corticosteroids will make it worse. So we don't give anything topical except artificial tears. We give NSAID PO. So florbiprofen is one of them. Sometimes if it's not so bad, naproxen, but it's really a systemic PO treatment of NSAID. And then if it doesn't work, then we'll go PO steroids. But both should be referred to us, which is good. The differentiation between scleritis and uveitis really is that the vision would be the same, the pain on palpation. Sometimes one of the big emergencies is if you see a black spot on the sclera, which I don't have in this photo. Do you guys know what it would be if there's a black spot?
Necrosis?
Yeah, so they can have necrosis. So we have two types of scleritis. You have non-necrotizing and you have necrotizing. The necrotizing one, they'll really lose vision in about a couple days, and they'll have a very bigger area of necrosis, and that obviously is an emergency to refer to us within the same day. Okay. All right.
Sorry,
So-
Nour, I'm just going to interrupt you for a sec. Are you in a clinic somewhere or something? There's a lot of background noise. I don't know if there's a door you can close or...
So I am in an open space. I can try to find a room. 1 second.
It's not too bad. It's just at times it's a little loud.
Give me 2 minutes. Is this better?
Yeah, much better.
Okay, great.
Thanks.
No problem. All right, so this is a 40-year-old patient. Welder, wasn't wearing eye protection, and now he has sensitivity to light and pain. What do you guys think is going to be on the next slide?
Foreign body.
Yeah, so a foreign body. Now, when would you guys CT versus not CT scan that patient with foreign body?
Same thing, RAPD, limited eye movement.
Yeah, what else?
If there is protrusion of the eye.
Yeah, definitely. So we would definitely, if there's an RAPD, we also would, if we start seeing a lot of inflammation in the eye or anything on the retina, we always dilate. We would scan. We always dilate the patient, especially if it's a high velocity. So grinding something, they tend to sometimes go through the globe. So do you guys remove it yourself? Have you, what do you use when you remove it? I don't know if any of you guys have done it. Or...
So cotton swab, I've never done it, but most of the staff have.
Also use a needle if you get a steady hand, and then they have the little tool that you guys have that like spins a little bit. We don't have it in Emerge, but some places do have it. Never used it though.
Okay. Yeah, you could definitely use a cotton swab. Sometimes it's a bit more embedded. So what you do is take a needle. You can use anything from 25 to 30. I wouldn't go with 18. It's you really need a steady hand. You could easily go through the cornea and just flick it off. We remove the rest ring a few days later. The rest tends to migrate anteriorly, so it's easier for us to remove it after a few days. And we would give also antibiotic in this patient. You create an ED by trying to remove the foreign body. So Vigamox, especially if it's an organic matter or metal, QID. So here, 35-year-old, it's a branch that hit the eye. The vision is a little decreased and the eye is red, photophobic. So this is a corneal abrasion. I'm not even going to ask you, it's very evident. But if there's a story of an organic matter, what's the really important things to do on exam other than just the fluorescein exam? Do you guys like invert the eyelids, look for other pieces of branches or debris?
Yes, we avert
Yes.
the eyelid.
Okay, so yeah, so basically it's just really important to avert the upper lid and the lower lid, irrigate if necessary if there's a lot of debris. Organic matters tend to be really nasty infections if they do happen. So for a patient like this, I wouldn't ask if they're wearing contact lenses or not. You would automatically go with the big gun, which is Vigamox QID, and refer to us. So you don't refer all the corneal abrasions, but so organic matter is plants, branches, and things like that, we should definitely see. All right. Now, if the patient wakes up in the middle of the night and this is what you see on exam, what would you guys go for?
Rupture du vitré.
Why would you say rupture du vitré? Maybe it's not a clear image. It's a cornea, and there's a big fluo uptake in the middle of the cornea, and he's in a lot of pain.
If it's a cornea, then I take my answer back.
Sorry, it's probably not, they're not the clearest photos. Yeah, it's just a big epithelial defect on the cornea. What do you guys think?
Ulcer?
So here, there's no white infiltrate. It's really just a big epithelial defect. It's just the layer, the first layer that's gone, but no white.
Herpetic ulcer?
Okay, well, these are actually really good DDXs. Definitely herpetic ulcer is one of them, especially if they don't have a lot of pain. And the other one would have just been a very large corneal abrasion. Some people tend to hit themselves with the nails, and other people, especially in their 50s or 60s, get something that we call recurrent erosion syndrome, where they'll just lose their epithelium. The tight junctions aren't as good, and they'll show up with a big epi defect. But I don't know who said the herpetic ulcer. That's very good and very high on the DDX. And if they don't have any pain, it should be treated with Valtrix. In these cases, though, they have a lot of pain. So 25-year-old contact lens wearer sleeps with them. You see white infiltrate in the cornea. The vision's decreased. So I know this is an ulcer. I know you guys can tell it's an ulcer, but how do you guys manage in the emergency?
You gotta think of Pseudomonas.
Yeah, definitely you have to think of Pseudomonas with contact lenses. And what do you tend to do? Do you prescribe antibiotics? Do you call us. Have you guys ever done cultures or?
I mean, this would be an immediate referral.
Yeah, it would be an immediate referral. Do you guys ever work in remote hospitals or?
Yeah, that's what I was gonna say. I think we're a little bit spoiled because we're all at academic hospitals. So for the most part, if we see this, we call you guys straight away. But obviously, that's a different story if we're working elsewhere.
Yeah, say you're working elsewhere. How would you guys manage this patient?
So as you said, cultures, I think I'd tend to use IV antibiotic on such a big ulcers.
And maybe irrigate too.
Okay. Anybody else? What would you culture with? Like, do you guys know? Okay, I'll go. Sorry, go ahead.
A little teeny tiny swab if you have one.
Okay, that's fine. So perhaps you just haven't had the chance to do it. I'll just go over it in case when you graduate, you work at a place where there's no ophthalmology. So the first thing we do is culture. So it's important not to give them antibiotics beforehand. So even if you have ophthalmology, don't give them antibiotics before you send them to us. It will alter the cultures. The way we culture it is that we put it on a blood, there's a blood culture that has to be done, chocolate plate as well, and a broth and agar. So every time you just take a swab, make sure you don't touch the eyelids. It's not a cotton swab. It depends what you have usually at the clinic, but they have really special culture swabs for the eye. If you don't have, I guess you can use cotton, but it's not the best for the cultures. And you just plot it on those plates. And then if you had to treat it, then we would go with the big guns. So we don't give IV antibiotics for ulcers, but we give vancomycin and tobramycin antibiotic drops. So these are not something that's readily available at every pharmacy. It has to be a compound pharmacy that makes them. There's different dosages, and we start these patients on every hour. So we then will wait for the culture to come back in 48 hours, and then we'll decrease it. So it has to be a slow taper every 2 hours, then 6 times, every 2 hours is almost 6 times a day, then 4 times a day, 3 times 2 or 1. If you do have the cultures and you have the sensitivities, then you could also remove either Vanco or Tobra. It's important to note that any antibiotic drop in the eye is toxic, so it will not help the epithelium heal, and you might have an abrasion or epi defect for a long time. So that's why we taper them quite rapidly. So yeah, then again, if you're at just to like rephrase everything, if you're by yourself, you would culture them, blood, agar, chocolate, and broth, and then you would start the antibiotics every hour. If you don't have a compound pharmacy, another alternative is Vigamux every hour as well, or 30 minutes. There's really no wrong. The only thing is once you've hit it strong for 48 hours, you should taper it because you're not helping the ulcer heal after 48 hours. So like someone said before, if contact lens, it's really, really important to think of Pseudomonas. Pseudomonas can ravage the eye quite fast. So a really low threshold to treat rapidly. Now they added this, I don't know how you feel about it, but sometimes we see a small pinpoint, less than 1 millimeter round white ulcer in the periphery next to the limbus. It won't have any fluid uptake. Some people say you could treat with Vigamux every hour, but I would say low threshold to refer if you can. If not, then yeah, definitely treat Vigamux every hour and then taper it after 48 hours. It's obviously evident to say that we see these patients daily, because if they're not improving, we have to switch the therapies. So here, 50-year-old farsighted. He was in a movie theater in the afternoon. The whole story is that it's a slowly progressing blurry vision, and then all of a sudden they have a lot of pain, the eye is red, they also have a headache. So what do you see on this exam?
So erythematous conjunctiva with dilated pupil on the left side.
Sorry, you cut. What's on the left side?
So the erythematous or conjunctival injection with dilated pupil on the left side.
Yeah. And what do you guys think? How's the cornea looking?
Looks hazy, looks dirty, kind of not clear.
Yeah. So what's the next test you would do on this patient?
Get an intraocular pressure.
Okay. And you're expecting it to give you what?
High number.
Yeah, or as your tonal pen does, it says error. So definitely after 60, the tonal pen isn't able to give you an IOP. So this is acute ankle closure glaucoma, like you all said. You'd have a hazy cornea, dilated pupil. It wouldn't be reactive. It could be a bit sluggish, and the eye is very red and painful. So this is an emergency referral. So they have some studies that say that there's significant vision loss after even just an hour. These are patients that we will treat heavily with max eye drops. Do you guys know? Are you guys familiar with eye drops or for glaucoma? Do you know what how many we?
Talking on a personal level, I think I'd like a refresher.
That's fine. So we have 4 kind of drops to decrease the pressure in the eye. So one is an alpha agonist. The other one is a beta blocker. We have prostaglandin and analogs and carbohydrate inhibitors. So we're lucky to have combination drops. So if you guys have, and usually the pharmacy will have Simbrinza and Duotrav, these are 2 different drops. Simbrinza, which will have the carbohydrate and the alpha agonist, and Duotrav will have the prostaglandin and the beta blocker. So you have your 4 drops right there to lower the pressure. We also tend to give Diamox to lower the pressure, and if these don't work, then we'll go and do a laser and open up the iris to relax the angle closure. But if ever you're up north or I don't know at another emergency, you don't have ophthalmology, try to hit them with the maximum drop therapy, give Diamox, and usually that's enough. So here, this is similar to the other patient, 38-year-old, vision a little bit decreased, the eyes is a little painful. I'm not going to go over it, ask you guys again, because you did say it when we were on this chloritis patient. But here, what you'll find is that the eye is red. They'll have a lot of photophobia. The pupil will be a little bit sluggish. It won't react the same as the other eye. And I don't know if you've ever seen those, but you can see cells here in the anterior chamber. There's these little white spots. The trick to seeing them is to put the light of the slit lamp at the maximum intensity, but to lower the slit beam to a very small 1 millimeter beam. So I don't know if it's clear, but really make it really small, but maximum intensity. And then try to put it at an angle to see between the cornea and the iris. It's really hard to see, even for PGY2s, it's really hard to see. So you could just try it for fun if you ever have a patient with a red eye. So for these patients, we treat with steroid drops. We give something called cyclogel, which is a dilator, but it also helps decrease the pain because they tend to have spasms, and we see every day as well. Okay, so this one is one of the big emergencies in ophthalmology. So patient who's had surgery a couple of days ago, now a lot of pain, the eye's red, the vision is light perception, and you can't see the pupil. So what do you think this is?
Endophthalmitis.
Yeah, so you should have a really low threshold to refer to us for this case. Endophthalmitis here, if you had to describe what would this be, what do you think the white here is?
It's a hypopion.
Yeah, it's a hypopion. The conjunctiva is very injected. There's a bit of subconcheme as well. So in these cases, we go back to surgery and we do vitrectomy to see what the antigen is, and we give intravitreal injections of antibiotics. So it's important to note, though, that it can happen after surgery, but it could also happen after a trauma. So if you have a big drop in vision, increase in pain, you should refer to ophthalmology. There are some cases that you can see this without any surgery and any trauma. Do you guys know what I'm referring to? If the patient has septicemia, diabetic, you could have endogenous endophthalmitis. It's very rare, but it's important to note. Have you guys seen a lot of endophthalmitis in the recent months in the emerged? Just out of curiosity.
Not at the children.
I haven't seen any either.
No? Okay. We've actually, it's important to note because recently we've had about 5 in the last month. We usually have 1 or 2 a year. So what we're thinking is that the masks that people have been wearing after surgery blows the air right up to their eye after. So there's been quite a few numbers of endophthalmitis. So just to keep in mind.
Now you're gonna give excuse for anti-maskers.
We won't say too loud, yeah. All right. So here, 35-year-old, decrease in vision for a few days, no trauma, no contact lens wear. They say they have pain, plus or minus. It's just a little bit irritated. What do you guys see?
Those are hyphae.
Herpes.
Yeah, herpes simplex. So the image on the left is the very beautiful textbook one. That's not what we tend to see. We usually tend to see these weird patchy, big epidefect areas. Like someone pointed before, it can be painful or it can be painless, and they won't have any kind of white infiltrate under it. If they do, then they probably have a secondary bacterial infection. So we would give Valtrex 1 gram BID for 7 to 8 days. These patients sometimes have to go on 500 once a day for months. So it's important to treat right away. So I know this is what you typically see, but do you guys know what other eye involvement herpes can have?
Episcleritis, keratitis.
Yeah. Uveitis. Do you guys know what it can give to the retina, or have you seen it? So herpes can be a very nasty bug, and what it can give is necrosis of the entire retina. It'll happen in patients who tend to have recurrent herpes infections. It doesn't have to be in the eye. They can have disseminated or, recurrent oral labialis HSV. And what it'll do to the eye is really just necrose the whole retina, give an RD and uveitis. These are the really intense cases, but that's why we see every patient with HSV keratitis. So this as well, if a patient comes in, like someone pointed out, just has a big epidefect, no pain, it's also HSV. So here, 74-year-old, forehead lesions, conjunctiva, a lesion on the forehead that are more vesicular and on the tip of the nose. How would you guys treat this patient? What is it and how would you treat it?
Zoster, so valaciclovir, but I don't know if you give some specific drops.
Yeah, so you're correct. That looks like zoster. So there's this, I mentioned the nose. Do you guys know I keep mentioning the tip of the nose for
Something
zoster?
called the Hutchinson sign, something like that.
Yeah, exactly. So the Hutchinson sign, if they have it, then they're more likely to have an eye involvement. So like you said previously, Valtrex, Valaciclovir, we don't give any eye drops in these patients unless the cornea is really hazy, then we'll tend to treat with steroids. But the Valtrex dose, whereas HSV was 1 gram PO BID, for zoster it's TID, and it's 7 to 10 days. We sometimes give erythromycin ointment on the skin lesion. So I just wanted to point out that there's two different ways to consult us. So if the vision decreases or the eye is red, then they're likely to have eye involvement right away. So we would see them the same day. If there's no signs or symptoms, so really the eye is white, the vision didn't decrease, then we don't see them right away. And the reason for that is even if the patient has no eye involvement on the first day, it will take them 5 days to develop uveitis if they ever do. So seeing them the same day will just, we won't see much, but if we see them in 5 days, then we'll catch a uveitis if they end up developing it. All right. So now 75-year-old patient fell from own height while getting out of the bed, hit her head on the side of the dresser, decreased vision and swelling. And here, what do you guys see?
Ça, c'est un décollement du vitré, non?
It's a globe rupture.
Okay, so do you guys want to describe like some of the signs that you see that makes you either say the décollement du vitré or the globe rupture?
There is teardrop sign.
Yeah, here. What else?
The conjunctiva est comme superposée. Là. Il y a comme un édème au niveau de la de la région péri-iris.
Oui, mais il y a, well, there's subconjunctive, so it's subconjunctive with the edema, which we often see. But the important point is that it's 360. So if you get either or, you don't automatically need to have the teardrop sign. But if you get 360 subconjunctive or the teardrop sign, then it's a globe rupture. Teardrop almost all the time, subconjunctive not always, but it's a very high likelihood. So it should be. We should be consulted, so open globe rupture in this case. So you should stop the examination. Don't put any drops in the eye. Don't take IOP. Don't take vision. It's really important to put a plastic eye shield over the eye. I think this is the thing that's always missing when we go see them in Emerge. Call ophthalmology and also do a CT head or orbit in those cases. It's important for us to see if we're, in this case, she fell and hit herself on a dresser, but sometimes there's foreign bodies involved or, you know, car accidents, we've seen glass, etc. Although they do get scanned automatically. So really important, if you see that teardrop sign or 360 subconjunctive, call us automatically. Even if the CT scan says that the globe is intact, we've had just last month a globe rupture where the CT scan read that the globe was intact. So watch out for these signs.
Why the plastic eye shield?
So because if they rub it, force, you know, they tend, it's quite painful, especially with the swelling. Some people tend to touch their eye, and every time someone touches it or any kind of rubbing, they'll expel more of the intraocular content out. So, I mean, obviously, if it's someone who's very aware, you know, like not intoxicated, it should be fine. But you also, they don't see from that eye, so they can hit themselves turning around or anything like that. You just don't want them to have it. And then in other cases, they're intoxicated, they'll rub their eye, they'll touch it, and it'll expel more of the content. The more content is expelled, the more likelihood they'll have an infection, and in these cases, they would need to be enucleated or worse.
Just from an examination point of view, sometimes when you have somebody coming in with the trauma, like exactly how you described, their whole face is like super swollen and you can barely even open the eyelid and you just see a bit of edema. So you don't necessarily see the full 360. At that point, is it like sometimes when I'm consulting ophthalmology, they'll ask me if there's really a 360 or not kind of thing, but I'm a bit timid about potentially opening up the eyelid further and exerting more pressure. Do you have any suggestions on, if we're being asked to examine further, or how to kind of avoid putting pressure on the eye, or I don't know. From that point of view.
Yeah, you guys have very challenging cases sometimes. There's really no trick like to try to not touch the eye. Perhaps go higher up and try to pull on the eyelid. I mean, even for us, sometimes if we're gonna forcefully open an eye that has a lot of edema, we're gonna put pressure on the globe. So I would just politely tell the ophthalmologist or whoever you're calling that it's not possible without putting pressure on the eye. And if there's going to be pressure on the eye, it should only be done once, and it should be done by the ophthalmology team then.
Okay, thanks.
Yeah, even the speculum, you're going to put pressure on the eye, so I wouldn't even give you that as a trick. And the reason we say no drops, don't put any drops, is because a lot of the drops are toxic if they become intraocular, and with an open globe, you don't want to risk that. So here we have the same scenario, the 74-year-old woman. She fell, she's on blood thinner. She has decreased vision, a lot of pain, and the eye is bulging, and it can't move left or right. What do you think this is?
Retroorbital hematoma.
Retroorbital hematoma, you see it really clearly here. So the pressure would be really, really high. There's a lot of mechanical pressure on the optic nerve. These are patients that need an urgent consult. Do you know how we treat it?
Lateral canthotomy?
Yeah, canthotomy, cantholysis, laterally, usually here. So we'll do a cut like this, and then try to find the tendon and cut down here. You see my mouse, right? So say you're up north and someone tells you to do it, really try to cut the lateral canthus horizontally, and then go inferiorly, try to cut the tendon. To be honest with you, when there's a lot of swelling, we don't really differentiate the different tendon or soft tissues, but you cut as much as you can and try to release the pressure. Drops won't do anything in these cases, so it's really surgical management.
Is it, how can I say, is it a procedure with a steep learning curve, or is it just something easy you can figure out, like draining down abscess?
If it's what?
Is it something that needs kind of training to do, like difficult, or is it something that can be figured out when I'm doing it? If I see a video, like I can do it immediately, or is it more complex than that?
No, I think you can do it. I personally think you could do it yourself. We personally get trained to do canthotomy, cantholysis in the surgical OR setting on a patient who has an elective case that's not swollen, which is not the reality. When these patients get retrobulbar hematoma, everything's swollen. You can't differentiate anyway. The important part is just to release as much tissue and decrease the IOP. So I think if you're there and you're willing to try, that's fine. These patients will lose vision within an hour, irreversible. So I mean, depending on where the ophthalmologist or someone who's trained is, I'd rather you try than, I mean, if it was me, but.
Stuff at EMREP has a really good video that makes it look really simple, but I don't know, it's on a cadaver, but yeah, I'm sure when it's super swollen, it's probably a little bit more difficult.
I've only had to do it once, and to be honest with you, and some of my co-residents will never have to do it throughout the residency. It's just a lottery on the call schedule, but we would watch a video before doing it, and that's it. So here's 40-year-old, works at the hospital cafeteria, splash of cleaning product in the eye, burning, decreased vision, and the eye is red. Vision is now 2500, very painful, and there's an epithelial defect. So what do you guys see on photo number 1?
Hazy cornea.
Yeah, hazy cornea. what can you tell on the conjunctiva?
Like chemosis, redness.
Yeah, quite a lot of chemosis and redness. On photo 2, what do you see here near the limbus?
The iritis kind of thing.
Well, if you just want to like describe what's the conjunctiva is all here, it's all red, but over here, how would you describe it?
Here's the limbus.
It's what?
Here's the limbus.
Yeah, so we call it blanching. It's white. It's completely white near the limbus. It looks abnormal. And then the rest of the images are just lesser, you know, here also more white. Here, these are just lesser intensities of what this would be. What is your guess on this patient?
It's a chemical injury, either acid or base.
Yeah, so which one is worse, alkali or acid?
Alkali.
Do you know why?
Because they, I think, cause more protein degradation.
Necrosis, coagulation.
Yeah, so these are all fair points. So basically acid chemicals will neutralize as they go through the cornea or the conjunctiva, but alkali will never neutralize. So they'll keep eating up whatever tissue they have. And so you'll get a globe rupture, a perforation with an alkali, which you won't get it with a mild acid. You will also get it with a very potent acid, but a mild one. They tend to neutralize before they do anything bad. So what's important to note here is the blanching. So these are signs of very poor outcome, poor prognosis. That means that the arteries are completely obliterated. They will get neovascularization, abnormal growth later on. If you do see a red on the conjunctiva, that's actually reassuring. But areas of white is actually problematic. How would you treat this patient?
Morgan-Lanz irrigation.
Yeah, Morgan-Lanz irrigation, quite a lot of liters. Do you know what the normal, sorry, pH, well, it said here, normal pH of the eye is 7 to 7.2. Of note, the pH strips that you have in the emerge are not made for the eye. So some of them, in some emerge, I think the RVH doesn't go below 7. So it's hard to define when you have an acidic injury, but you can use it for alkali. The other ones, they're not actually very accurate. So what you have to do is measure in both eyes to make sure that the pH is the same. So we'll tend, with these pH strips, sorry, someone just walked by, that's why I was not concentrated. So what you have to do is you take it in both eyes, because those pH strips, they'll tend to give you a pH of 8 in the eye. So if the unaffected eye is showing you 8 and the affected eye is showing you 8 as well, you can be reassured that you've done enough for irrigation and you don't need to continue because, like I said, they're not made for pH of the eye. You should consult ophthalmology the same day, especially if it's a high alkali or high acid. Look for hidden particles. Sometimes they can keep releasing chemicals onto the eye. So flip the eyelids superiorly and inferiorly. If there's ED afterwards, then we'll give Vigamox. Sometimes we'll give Pret Forte to decrease the inflammation. And in the worst cases, so especially when they get blanching, we will put amniotic membrane in the OR afterwards. I think someone just asked a question on the chat. What do I think of Defoterine? To be honest, I'm not very familiar with it. I know it's a eye wash some emergencies use, but I don't know much enough about it to comment. Do you guys use it here or?
I was the one that answered the question. We're looking at potentially getting it. Okay. Certainly on site, it works for alkali and acid, and it has a particular way that it works in terms of the positive and negative charges. And without going into detail on it, it's supposed to work. Like if you put it on within 10 seconds, within 1 minute, your pH is resolved. So that's in the beginning, but they say if it's used in the field, then you should continue when they come in. Like ideally they would get another wash with it. And it really resolves the pH issue pretty much like within several minutes instead of like an hour or 2 hours of irrigation. And at least the literature I looked at, there's some controversy over it, but it's widespread use in Europe. And we're starting to see it being used actually locally in some industries. And I think there's a few hospital emergency rooms that have it. So I think it'd be a great cat topic for somebody. And yeah, and perhaps get a real opinion from ophthalmology on that. Should we all have it in our emergency rooms, or you don't think it's worthwhile?
So I can look into it and ask my staff, and I can send an email to Audrey since I have your email.
Great.
Okay, that's interesting. Thank you for bringing this up. Okay, so that was it for the cases. So this is the same list as at the beginning, a little bit of everything. So from this list, which one would you say is painful? If you have a painful red eye, what's your DDX? Not
You
all
want
at
to
the
know?
same time. Yeah.
You want to know from the slide which one
Yeah.
are painful?
Yeah, exactly. Sorry. Yeah. Say you have a painful red eye. Which one from this DDX would you point out as being painful?
Well, preceptal and orbital cellulitis will be painful.
No, sorry, I pressed by accident, but you can. Retrobulbar, yes. Retrobulbar hemorrhages, scleritis, corneal foreign body, abrasions. So anything in a healthy cornea, if there's any kind of epi defect, it'll be painful. Angle closure, glaucoma, uveitis is also painful, and definitely endophthalmitis. Sorry, I cut you off. I pressed on the button by accident. So here, which one would give you a severely decreased in vision? I don't know if someone can tell me in the adnexial, which one would give you a severely decreased in vision?
Retrobulbar hemorrhage definitely could. Orbital cellulitis could as well.
Yeah, that's very good. And the conjunctival sclera.
Episcleritis and scleritis.
Okay, so episcleritis won't give you any change in vision. It'll be episcleritis is actually a very benign diagnosis where the conjunctiva is red, there's not much edema, doesn't change in vision, it's not painful, and when we do tests for any kind of inflammatory disease, they're all negative. But scleritis can sometimes, although rare, for cornea.
I guess a large
ulcer.
And a large central abrasion as well could.
Yeah, a large central abrasion ulcer. For the anterior chamber, obviously, ankle closure glaucoma, some uveitis sometimes, hyphema only when it's quite large, and for endophthalmitis. Yep. Here recently, post-operative, you can have retrobulbar hemorrhages, especially in patients who have any kind of orbit surgery. You could have subconch hemorrhage, corneal abrasion. You can also have an angle closure glaucoma after a recent surgery, especially cataracts, so something to look out for. Now, I don't know which one he highlighted, but if you had to point out which one is the younger, you'd see more in a younger population, what would you say?
Chalazion, preceptal and orbital cellulitis.
Yeah.
Conjunctivitis, most likely viral, but could be all of them.
Yeah.
Corneal abrasion.
Yeah, as well, younger, yeah. Uveitis as well. Okay. So I know these are big lists. You guys actually seem very familiar with the ophtho red eye diagnosis. You seem pretty sharp on your DDXs. I'm happy to help out if ever you have questions when you're on call, or if you want the slides or anything like that, I can send them to Audrey, or she can share my contact. I really have no problem. That was the end of the presentation. So just to point out that obviously good history can help you with the DDX. What's important to us when you call us is the age of the patient. What's the chief concern? If they have past ocular history, definitely helps. And on exam, what helps us triage them is really vision, pupil, extraocular movement, and intraocular pressure. I don't know if you guys actually try to do digital palpation. It's really not reliable. The only thing you can tell is if one eye is really, really hard for angle closure glaucoma and the other isn't, then you can tell the difference between the two, but otherwise it's not a reliable way to measure the pressure. And the slit lamp exam, always a bonus if you guys want to try to find cells in the anterior chamber. So that was all. Sorry we couldn't do the slit lamp workshop afterwards, but hopefully in another year, next year.
Okay, thanks very much, Nour. Does anybody have any other questions, either about examining or questions, how to refer, when to refer, or anything else? We have a couple of thank yous in the chat.
Quick question. As a newer one, I'm always afraid to use drops when I do my exams, because I always have the impression that I either won't use the good one or make it worse, or like I'm always afraid to use those little drops. Do you have any suggestions or not to do, or like, oh yeah, you can use it pretty much every time except this and that?
So you can definitely use them anytime. I think in the ER, you only tend to use tetracaine or alkane numbing drop to measure the pressure, and then to put the fluorescein strip to look for epithelial defect. I've never seen you guys use dilating drops. And if you do, please let us know. It's happened that a patient was dilated and we weren't made aware. So if you use tetracaine and alkane, there's really there's no situation where you would harm the patient except for a globe rupture. So I would use it without worrying too much. The only other thing is if you have a patient that has a corneal abrasion, it's very painful, and they will like the drop that you put in the eye, the tetracaine or alkane. Do not give it to them. It inhibits healing of the epithelium, and they will end up having very complicated corneal abrasions, sometimes the whole cornea, and will do them more harm. So really tell them to take Tylenol or Advil for the pain, and a corneal abrasion heals in less than 24 hours. So that's the only warning I would give on those drops, is not to give it to a patient with an abrasion.
All right, thanks.
No problem.
Anybody else? Okay. All right, thanks very much, Nour.
Thank you guys. Bye-bye.
Bye.